Hello, this is the sixth lecture that we'll cover in our course of behavioral science. The previous two lectures were on the developmental psychology or psychology of development, and those lectures basically cover the great milestones in the lifetime of an individual from the moment they're born all the way into adulthood. Today we'll cover some of the aspects of psychology when individuals reach the end of their lives. That is to say, when they age, when they die, and how other individuals cope with a loved one's death, which is a grief and bereavement. So this is going to be basically the third lecture in the topic of developmental psychology. But it also will introduce a disorder that is covered in the DSM-5. Keep in mind that the DSM is the Diagnostical Statistical Manual that is used in psychiatry. It is currently in its 5th edition. So this is, at least in the American setting, in Europe it's a little bit different, but in America, this is, so to speak, the Bible of psychiatry, because it's where all the mental disorders are categorized and where the criteria for diagnosis is given. So we will we'll take a look at these disorders with much greater detail later on, but today will be the first one that we'll introduce, and this is the first time we're actually using the DSM, so it's important for you to know what the DSM is. And just to let you know that every time there's a new edition, there are some changes in the DSM. And usually the way this works is that a group of American psychiatrists get together and they discuss some of the mental disorders that are in the previous editions, and they vote on what the changes should be for the next editions. Okay, so let's begin with aging, death, and bereavement then. Keep in mind that all of these topics are included in the USMLE. So when we finish today's lecture, we'll do some review questions that resemble the ones that appear in the USMLE and that have to do with today's topic. So let's begin with the topic of life expectancy. Well, life expectancy is the statistic of how long do people live throughout the world. In the United States, it is about 76 years old. So that's the mean age when people die in America. There has been a dramatic increase of life expectancy throughout modern times. I mean, if you go back 2 or 3 centuries ago, life expectancy was very, or far lower than today. And there's a lot of people who complain about how wonderful life was in the past and how terrible it is today. But I don't think they get the whole picture. I mean, if, at least in terms of life expectancy, we have a much better situation right now. In the United States, people die around the age of 76. Usually for women, life expectancy across all countries is usually a little bit longer, and that may be due to a number of different reasons. The most common hypothesis has to do with the fact that since men are more involved in labor activities, well, that so to speak wears them down more, or they have more stress. So the more stressful you are, well, the less you're expected to live. And actually, you can see some pictures of American presidents of how they were before and how they are now. And, you know, being an American president is a job that has a lot of stress, and that makes you age quicker. So that's why, that's one of the hypotheses over why women have a longer life expectancy than men. So it varies by race and gender, although differences in life expectancy have been decreasing over the last few years. So at first, women were at an advantage, but over the last few years, it has been more equalized. Usually, obviously, social economic groups and ethnic groups that are more privileged than others. So for instance, in the United States, whites over blacks because, well, blacks because of all the history of racism and slavery and so on. Usually the groups that are more privileged have a higher life expectancy. And it could also be said that that's the way it works worldwide. Countries with higher socioeconomic variables, with socioeconomic indexes, they usually have a higher life expectancy. Although it's not a perfect correlation, because the United States is maybe the most powerful country in the world, but it's not necessarily the country with the greatest life expectancy. But overall, it is true that the better, the more developed a country is, and the better the lifestyle, well, the greater the life expectancy. It's important to know here two terms that we'll be using and that physicians use all the time. One is gerontology, and gerontology is the study of aging, whereas geriatrics is the care of the elderly. So we'll take a look at this as we go on. Okay, so here is a map of life expectancy across the world. As I was telling you, those countries that are in the darker shade have a higher life expectancy, whereas those countries with a lighter shade have a shorter life expectancy. You can make the case that the more developed a country is, the more economically prosperous, the more safe in terms of security, the less crime there is, and so on. Well, the greater the chance a person living in that country has of increasing their lifespan. But of course, within each country, there are differences too, especially if the country is ethnically or socioeconomically diverse. So you see the United States there has a darker shade, but I bet that if we take a map of the United States, we can see that ethnic groups that are more marginalized, such as African Americans or Latinos or Native Americans, their life expectancy is lower. So this is an important variable that is taken into account usually by the United Nations or other institutions to watch the development of countries. Life expectancy is usually a priority. So you can tell a lot about how well a country is working depending on how long people live. Now let's keep in mind that social development is not the only factor in longevity. I mean, there are other factors as well, including genetic factors. So a family history of longevity is important. I mean, there have been studies and finding out that people who tend to die in older age, well, that trait runs in the family. So genes do have a part. But it also has to do with the environment, so continuation of physical and occupational activity. If you're too, as I was saying, if you're too stressed during your work years, well, that will eventually take a toll on you, and that will decrease your life expectancy. Also, advanced education. Yeah, if you have a higher level of education, you probably know how to take care of yourself better. I mean, you come to learn the importance of doing exercise, of having a proper diet, of not abusing substances or drugs, of having healthy habits, of going to the doctor. All of that is learned in education. So those countries that have a good educational system usually tend to have a greater life expectancy. And of course, social support systems, such as including marriage. So those people who decide not to marry, who choose to stay celibate, those people do not tend to have longevity in the same rate as people who are married or who have relatives. Human beings are social animals, and our wellness or welfare depends on how well we're integrated with other people and how other people support us. So married people usually tend to live healthier lives. This is a fact, and therefore they usually tend to have a longer lives. So longevity is significantly affected also by the way people interact with others. And, you know, being married is a factor that increases longevity. When it comes to longevity, there is also an ethical question. I mean, how far should the quest for longevity go? Should we try to, should you as physicians try to suspend death indefinitely, or does it come a time when you say, okay, look, people have lived for long enough, and we should not be looking for longevity anymore. Let just people die a natural death, and let's not prolong the lifespan anymore. And this is an active area of philosophical discussion and medical ethics. And remember that here in behavioral science, although the first two topics were devoted to the issue of ethics, we will always come around ethics because behavioral science and medical ethics always go hand in hand. So there's a lot of ethical discussion about how far should the quest for lifespan extension or even immortality, how far should we take that? Now, if you take a look at religious traditions, including Christianity, Islam, or Judaism, but that's not the only one. Basically, all religious traditions have the promise of immortality. For instance, the Epic of Gilgamesh, which is probably the first book to ever be written, is the first piece of written literature. It tells the story of a hero in Mesopotamia, which is current-day Iraq, who goes out to look for immortality. And he never achieves it. He comes close to achieving it, but he ultimately fails. And this is a cultural depiction of the cultural and social anxiety that all societies have regarding mortality and immortality. I mean, no one really wants to die. Or there's a famous saying, everybody wants to go to heaven, but nobody wants to die. So it looks like immortality and lifespan indefinite extension is something that we all want. And it's very natural for human beings to desire that. Now, there are some scientists, some of them are physicians, but some others are biologists and engineers, who are proposing the idea of transhumanism. Now, transhumanism is the project that attempts to achieve immortality through indefinite life extension. So what religions promise, but nobody has been able to deliver yet, which is not dying or immortality, well, transhumanists are also promising this, but it seems like they have a more concrete plan to carry out that promise. I mean, religion promises this in a mystical fashion, you know, not really providing a rational plan to achieve it, whereas transhumanists are proposing something that is much more rational to achieve it. And the main person who is behind this project is a famous British scientist. His name is Aubrey de Grey, and he has proposed the so-called strategies for engineer negligible senescence. Now, negligible senescence is a concept that consists in that some animal species do not show signs of aging. So there are some species that it's difficult, you know, just by looking at them, it's difficult to tell whether they are young or old. And it's because their cellular processes are a little different from ours. That's what they call negligible senescence. So there are no really symptoms of aging in those species. Now, what some of these biologists and engineers are attempting to do is to work on the cellular level in order to engineer negligible senescence. That is to say, to stop the symptoms of aging in our species. And if they are able to do that indefinitely, then that would prevent death indefinitely. So basically, this is a project that attempts to engineer cells in order to prevent them from becoming deteriorated, so that with the constant renewal of not probably the renewal, but with the engineered negligible senescence, and that is to say, trying to avoid the body from aging, the hope is to suspend immortality indefinitely, to suspend death indefinitely. Now, to some people, this may sound like a wonderful project, but among physicians and among ethicists and philosophers, there are some ethical objections to indefinite lifespan. Well, first of all, there's a problem of overpopulation. if nobody dies, then the planet will sure be overcrowded. And so far, we don't have a big overpopulation problem going on right now. But in some areas of the world, it is a big problem. If you go to places, I have been to some of these places. If you go to Delhi, for instance, in India, or for instance, last year I spent some months living in the Marshall Islands, in the city of Majuro, that was hugely overcrowded. And here in the Western Hemisphere, in Latin America, for instance, Haiti is overcrowded. Mexico City is overcrowded. So overcrowding presents all sorts of problems. Now, one way to handle overcrowding is that the older generation dies, and well, that provides some spaces for new people. But if new people are born every time and the old people do not die, well, the population number will increase indefinitely, and that will certainly make life miserable. So overpopulation may be a problem in this project of not dying, and there may be some ethical objections because of that. There's also the problem of boredom and the meaning of life. I mean, there are some people who say that life acquires a meaning when you come to understand that there will be a time when you will not live anymore. So death allows you to appreciate the fullness of life. If there is no death, then you will not be able to appreciate how wonderful life is. And if you spend a whole lifetime without dying, then some people speculate that there will come a time when you will become terribly bored. So this is another ethical objection to this project. There's also the concern that there could be a huge increase of social inequalities. If some people have the gift of immortality, if some people have access to these technologies to prevent death, but other people don't, then this will increase social inequalities because there will be one group of people who are the mortals and one group of people who are the immortals. And this could lead to all sorts of dystopian science fiction scenarios when there would be like a master class and not necessarily a slave class, but a mortal class and an immortal class. And this would be very akin to societies that, very much as the United States in the past, would be severely unequal, and that could cause all sorts of social problems. Usually sociologists tell us that there is a strong correlation between social inequality and crime, for instance. So if this project of immortality brings about an increase of social inequalities, that could also increase crime, and this could be a problem. There's also the objection that the old will outnumber the young, and this is related to overpopulation. So there will be more older people than younger people, and this may eventually turn into what's called a gerontocracy, that is to say, a rule by older people. And usually gerontocracies are not very kind. For instance, the Vatican is pretty much a gerontocracy, and there have been a lot of complaints about how older people usually oppress younger people in societies such as those. So there is that danger. And also there is a problem of the quality of life, and that is that the extension of lifespan does not necessarily guarantee health. So it may be that you go on to live indefinitely, but not necessarily having a healthy lifestyle. So you may reach, you may become very, very old, let's say to live for 200, 300, or 400 years. But what good is it to live for centuries without having a healthy lifestyle and without enjoying good health? So that's another concern for these projects. Okay, so let's leave ethics aside and let's talk a little bit about some of the somatic and neurological changes that go on as people age. Well, first of all, as you probably know, strength and health decline, and there is impaired vision, so people do not see as well as they age. There is impaired hearing, so that's why older people usually need hearing aids. There is a decreased immune response, so older people are at a greater risk of infection. There are decreased muscle mass. We talked about this in the previous class, how muscular development usually peaks around the late or mid-late 30s. So Obviously, when people age and they become elderly, their muscle mass decreases, and also they are not as strong as they used to be. They have increased fat deposits, so they on the one hand they may lose weight because they do not have the same muscle mass, but on the other hand, and they may also increase weight because they have greater fat deposits. Osteoporosis, that is to say that their bones become more fragile, so there are greater risks of fractures in older people. And there is also a decreased renal function. This has to do with the kidneys, pulmonary, with the lungs, and gastrointestinal. So all the digestive systems becomes weaker, and there are higher risks of developing diseases there. And there's also, in people that are more advanced in age, reduced bladder control. So very much as children, senior citizens, or the elderly, the more they age, the greater the risk there is that they may pee or poo on themselves. There are also changes in the brain, and of course this affects behavior, because as you know, the psychological is the biological. So in elderly people, there is a decreased weight of the brain. This may have some behavioral implications. Physicians and biologists are not so sure that there is a absolutely neat correlation between size of the brain and weight of the brain and intelligence and cognitive abilities. Not necessarily having a larger head will make you smart. That's a media myth. But there does appear to be some correlation in the fact that as people age, some of their cognitive abilities may be a little bit impaired, and the weight of their brain decreases a little bit. Now, their ventricles, that is to say, the space, the empty or the void spaces that are in the brain, they become enlarged. And when we talk about schizophrenia, we'll see that this is also a symptom of people with schizophrenia, and to some extent that impairs their cognitive capacities, both in the case of schizophrenia and in the case of aging, of elderly people. Now, of course, the cognitive impairment in schizophrenia is not to the same level as the cognitive impairment in the elderly. I mean, it's much more severe in schizophrenia. But there is also decreased cerebral blood flow. So, the blood does not run as fluidly in the brain when you reach a certain age. Also in the brain, there can be senile plaques, but not to the extent that happens in Alzheimer's disease. Alzheimer's disease is characterized by senile plaques that affects brain functioning, and that, of course, that ultimately leads to some dramatic changes in behavior and cognitive impairment. So let's talk about some of the cognitive changes. Well, as I was saying, there may be some decrease in cognitive abilities, but overall, there's basically the same intelligence, although lower learning speed and also longer reaction times. So these are some of the cognitive changes that you can expect in people that age. There may be some slight memory problems, especially regarding short-term memories. Now, it is a significant fact that people who age, or elderly people, they tend to remember better things far in the past than things that just happen immediately. So they can talk without problems about their youth, but they may have forgotten where they put their keys a couple of days ago, or things like that. And this is a phenomenon that's very frequent in elderly people. Although there might be some cognitive changes, for the most part, they're not significant enough to impede a patient from living alone. Sometimes relatives and social workers and people who take care of the elderly, they tend to underestimate the elderly, and they may think, oh, they cannot live on their own because they're not able to take care of themselves anymore. We have to call in, we have to bring them into a nursing home, or we have to bring in someone to take care of them. And that may certainly be the case sometimes, but sometimes I think that there is an excessive concern with that, because although there may be some cognitive changes, they're not necessarily significant enough to forbid a patient from living alone. Okay, during old age, there are also some psychological changes that are important to consider. Let's go back to Erikson's theory regarding how during each phase of development the individual has to face a dichotomy or two categories about how to behave and how to decide on what they must do. So according to Erikson's theory, during old age, that is to say after 65 or 70 years old, the individual has to decide whether or not they should give more preference to ego integrity or despair. And this basically comes down to how satisfied an individual is with their lifetime achievements in the past. So if the individual had a good life and he's satisfied with the things he did in the past, and this basically amounts to work, to family, and to doing good deeds, and to professional development and self-fulfillment, then that individual will have a strong ego integrity. I mean, the individual will feel satisfied. But if the individual looks at the past and he doesn't feel that he has really achieved anything important, and he regrets having missed a lot of opportunities and so on, then the individual may enter into despair. So ego integrity versus despair is a dilemma that older people have to face as they approach the end of their lives. There's also an increased risk of depression during advanced age. So in elderly people, there is a higher risk of suicide than in the general population. So this is something that physicians need to watch for always. And remember that in the cases that the physician, or especially the psychiatrist, may suspect that the patient may pose a danger to himself or to others, then in those cases, involuntary hospitalization is ethically permissible. So physicians need to know the epidemiological facts of suicide, and epidemiology tells us that elderly people are at a higher risk of suicide than the rest of the population. So that's something to watch for, especially when it comes to involuntary hospitalization. Now, when making diagnosis, you as physicians have to be careful not to confuse one disorder with another. And this is why the DSM-5 for every disorder includes a section on differential diagnosis. So when it comes to depression in elderly people, there is always a risk of confusing depression with Alzheimer's or with symptoms of Alzheimer's. So depression may be diagnosed as Alzheimer's. So you have to make sure that you make a right diagnosis, because of course treatment will change. So you have to know very well the symptoms of each in order to avoid confusion. When we get to mood disorders in the DSM-5, we'll cover them in more detail. There is also, when it comes to psychological changes in elderly people, what's called pseudo-dementia. That is to say, memory loss and cognitive problems, but not necessarily Alzheimer's. So again, depression may be diagnosed as Alzheimer, and also when people diagnose Alzheimer, there is a risk that it may not actually be Alzheimer, but actually pseudo-dementia, which is a different disorder. It's when people apparently have some memory loss and cognitive problems, but the etiology is different from Alzheimer's, and of course the treatment will also be different. When it comes to all these problems of depression, pseudo-dementia, and so on, well, the treatment is usually supportive psychotherapy. So as I was telling you, when patients are married, especially when they reach older age, and they're married and they have support from their families and so on, they have a much better prognosis than people who choose to stay celibate and are not supported by any relatives because there are no relatives around. So when it comes to treatment, psychotherapy, and that is to say talking cures, and in a future lecture we'll go into some more detail about the different types of psychotherapy that there are around. Psychotherapy is the first-line treatment for depression in elderly people. And of course, that comes with the support of other people as well. In more extreme cases, there can be pharmacological treatment, and usually here antidepressants are prescribed. SSRIs, which are selective serotonin reuptake inhibitors, or MAOIs, monoamine oxidase inhibitors. And if the depression is severe enough, another line of treatment could also be electroconvulsive therapy. Now, electroconvulsive therapy has been controversial among some people, and you can see there in that slide an image of Jack Nicholson receiving electroconvulsive therapy. You may remember from a previous lecture that we talked about this movie, which is very famous in the history of film. And this movie is One Flew Over the Cuckoo's Nest. And the movie is a big criticism of psychiatry. And they perform two types of treatments there. On the one hand, they perform lobotomies. And we already talked about how deeply unethical lobotomies are. Lobotomy is cutting the circuits of the frontal lobe, but that has huge cognitive impairment effects. So, today it is no longer used, and it is considered to be deeply unethical to use them. And the film also criticizes electroconvulsive therapy, which is basically sending some electrical charges on the brain. The mechanism is not all that known because it's not that well understood, but it's basically an stimulation for depressed people. Now, in the past, people have labeled some criticisms because they may think that it's too invasive and so on. But and it may have been brutal in the past because it used to be performed without anesthesia. But today things have changed, and there are not really any ethical objections to the use of electroconvulsive therapy, as long as it is voluntary, keeping with the principle of autonomy that we discuss in medical ethics. Things have changed today with electroconvulsive therapy, especially for the elderly, because first of all, it's used with anesthesia, so the patient doesn't really suffer. And there is also the aid of muscular relaxation and oxygenation. And of course, as I was saying, it is performed, this therapy, with informed consent. Now, it is true that there are risks, and those risks are associated with fracture, because as the therapy is being performed and the patient has some sudden movements, and there may be some dangers of fracture there. And it is true that one side effect of electroconvulsive therapy is memory loss, but it's not really that great, and the benefits for the most part outweigh the side effects. So there is a high rate of success in this therapy, and it is no longer controversial, although at a certain time in the history of psychiatry it was certainly controversial. Okay, let's talk about some other psychological changes that elderly people go through. Well, first of all, there is a decreased ability to sleep there, so there is a loss of sleep and poor sleep quality. There is also an anxiety and fearfulness over real dangers. As people age and they become elderly, there's an increased risk of being dependent of others because they don't have the same physical strength, and perhaps their cognitive abilities are impaired. Although they may still be able to live by themselves, as I said previously, their anxiety may increase, and also their fearfulness over the danger of having to be dependent of other people, and also on developing illnesses. And of course, when we talked about when we cover the DSM-5, we'll cover a disorder that's called illness anxiety disorder, that used to be called hypochondriasis. But in those cases, the anxiety is blown out of proportion to the real dangers. Here in people that are elderly, the anxiety and the concern is not all that blown out of proportion because the danger is more real. So this is like a psychological important change that the elderly people go through. And also there's an increased risk of abusing alcohol. when it comes to elderly people. So alcohol-related disorders are often unidentified, but they are present in about 10 to 15% of the geriatric population. So this is usually not all that's spoken of. When we think of alcohol abuse, we usually think of fraternity kids and so on. And that may be true, but it's also true that elderly people are also at a risk. And unfortunately, the media dedicates much more attention to what frat kids, how fraternity kids get drunk, and that overshadows how how elderly people may also be suffering from alcohol-related disorders. All right, so let's now turn to dying and the psychology of dying. There was a very famous psychiatrist. Her name was Elizabeth Kubler-Ross, and she talked about different stages in the psychology of dying. How when people learn that they have a terminal condition, what psychological changes they go through. And there are at least 5 stages that people go through when they find out about their terminal condition. According to Kubler-Ross, the first one is denial. So the patient refuses to believe that she is dying. So maybe the doctor has broken the news that they have terminal cancer. The patient just doesn't accept it. They say, "Oh no, that doctor doesn't know what he's talking about. This can't happen to me. I don't have this condition." But eventually, the news come in, and the patient stops denying it, and he comes to understand that yes, indeed, he has a terminal condition, and the next process will be anger. So the patient will become angry at the physician and the hospital staff. It's hard for us to understand that sometimes that eventually we'll have to die, and that most of the time it's really no one's fault. That's just the way nature works. But psychologically, for the patient, this is difficult to assimilate. So usually the patient will become angry at someone. And of course, the people who are most likely to be the object of that anger are the doctors themselves. So it's important for you physicians to understand these processes in order to cope better with them, and to make you be aware that there is an increased possibility that the patient will turn hostile towards you. It's pretty normal, so you need to be more tolerant of this. Then there is bargaining. The patient may try to strike a bargain with God or with some higher being. So, look, God, if you save me from this disease, I will promise to be a better person. I will promise to give to charity, and so on. And some people may say that this is an irrational response because, if you have a terminal disease, praying won't save you. But it may be irrational, but nevertheless, it's a normal response. And no matter how rational you may be throughout your lifetime, there is an increased chance that you will engage in this type of bargaining when you're diagnosed with a terminal illness. Then there is depression. The patient becomes very worried with death. They may have some also death anxiety, and they may become emotionally detached. So the relatives may be concerned about how the patient is doing, and the patient, being depressed, there may come a time when the patient just doesn't care about having emotional attachment to the relatives or to friends. So this is a very challenging situation. And ultimately, there is acceptance. So the patient, after having gone through all those difficult previous stages, then the patient becomes calm, and the patient accepts her fate and says, well, I have this terminal condition, there's nothing I can do about it, so I might as well accept it and die in a very calm fashion. Now, psychologists and psychiatrists also pay close attention to the psychological processes of grief, and what are the normal psychological responses when when loved ones die. So in the DSM-4, there was a difference between grief and depression, and some psychologists still use it to this day. So when other people die, it is normal If we love those people, it is normal to feel pain. But there is a difference between feeling that pain and being depressed. So in people that have grief, they may have minor weight loss, whereas in depression there is significant weight loss. In grieving people, there may be minor sleep disturbances. In depression, there are significant sleep disturbances. In grief, there can be mild guilt feelings, such as, oh, my mother died and I feel guilty because I didn't take care of her as much as I should have. But it's relatively mild, whereas in depression, there are intense feelings of guilt and worthlessness. In grief, there may be some rather sporadic episodes of illusions. So, for instance, thinking very briefly that one sees the deceased person. This is very common amongst widows, especially during the first few days after the husband's death. They may have the illusion that all of a sudden the deceased husband appears in the bedroom or something like that. But as I said, these are very brief episodes. Whereas in depression, there can be hallucinations and delusions, which are more elaborate things. For instance, hearing the dead person talking and having encounters with them that are, prolonged in time. That's very different from a brief episode. In grief, there are attempts to return to work and social activities. Whereas in depression, the depressed patient doesn't have really any interest in resuming work or social activities. It is normal for a person with grief to cry and experience sadness, whereas in depression, it's a far more serious matter, to the point that the depressed person may consider suicide. Usually in grief, symptoms resolve within 2 months, whereas in depression, the symptoms go on for more than 2 months. In grief, the moderate symptoms subside within a year. In depression, the moderate symptoms persist for more than 1 year. And when it comes to grief, and this is a very important difference in treatment, for grief, treatment includes increased calls and visits to the physician, especially supportive psychotherapy, and perhaps pharmacological treatment that includes short-acting benzodiazepines for temporary problems with sleep. Whereas depression, it may require more intense therapy, either psychotherapy or pharmacological therapy. So the treatment may include antidepressants, antipsychotics, if the patient gets to a point of hallucinations and delusions and other psychotic symptoms. Or if the depression is severe enough, then maybe a line of treatment could be electroconvulsive therapy. Now, let's keep in mind that what I just mentioned is according to the DSM-4 criteria. But there were some changes in DSM-5 regarding grief and bereavement. In DSM-4, when it came to major depressive disorder, and this is a disorder that we will cover later on, there was the bereavement exclusion. That is to say, if a person had the symptoms of a major depressive disorder, but that person was grieving the loss of a relative, then the DSM-4 instructed the psychiatrist not to diagnose major depressive disorder. Now that changed. In the DSM-4, the individual would not be diagnosed with an MDD if he was grieving for 2 months after the death of a loved one. In DSM-5, that changed. So a person who loses a relative but becomes extremely depressed, even prior to the first 2 months of bereavement, that person may already be diagnosed with a major depressive disorder. And the reason for this, it was because persons with acute grief are more likely to develop MDD. So the DSM-5 took the precaution that if this was diagnosed on time, before waiting for the 2 months of grief and bereavement, treatment could be it could be applied more quickly, and there could be a greater chance for a better prognosis if the major depressive disorder was diagnosed on time and treatment began promptly. And in the DSM-5, there is a proposed disorder that was not yet included, but it was proposed for future revisions of the DSM. And this disorder is called the persistent complex bereavement disorder. So it is proposed but not yet included in DSM-5. And the proposed criteria is, well, in order for an individual to be diagnosed with this, first of all, the individual has to experience the death of a loved one. B, one or more of these symptoms for 12 months have to be present. And these symptoms are persistent longing for the disease. So this, the individual may be thinking all the time of the deceased person. He may be saying, oh, I wish that, so and so were here with us, but he isn't, and that makes me very sad. So, persistent thinking about or desiring that the person were here, not letting go of the person. Intense sorrow, so this is intense sadness over the death of a relative. Preoccupation with the deceased. I mean, for normal people, when a person dies, well, the person is dead, and there is really nothing else to worry about the fate of that person. That person is already dead, and there's nothing we can do about it anymore. If a person may be suffering from this disorder, well, one of the symptoms could be that the person is intensely preoccupied with the disease as if that person were still alive. Another one of these symptoms is preoccupation with the circumstances of death. So the person may be thinking all the time about how their loved one died, and that may impair them for other social activities if they're thinking all the time about how their loved one died and what were their circumstances of their death. And as well as one of those symptoms, the DSM also requires one of these additional symptoms for at least 12 months. So first of all, there is the difficulty of accepting death. And there is a disbelief or emotional numbness. So this is when people have a hard time accepting that the other person died, and they just can't believe it, and they're having a difficulty expressing emotional affairs because they're still in a state of shock. They may have difficulty with reminiscences of the deceased, so every time they think, it's hard for them to think or to remember the deceased person because that may cause them intense grief. Bitterness or anger over the loss, maladaptive appraisals about the death of the loved one, so self-blame, for instance, so saying, oh, constantly, he died because of me, it was my fault, and so on. Number 6, avoidance of reminders of the loss, so going over the dressing room or the perfumes or the belongings of the deceased person, avoiding those objects because out of fear that those objects may remind the patient of the loved one's death, and that's another symptom. Number 7, a desire to die in order to meet the disease in the afterlife. Number 8, not trusting other people. Number 9, feeling alone or detached, which is much related to the other symptom that was emotional numbness or disbelief. Number 10, feeling that life is meaningless, not finding any pleasure in any activities. Number 11, a diminished sense of one's identity. So this is related to dissociative disorders. When people go through some stress, through some intense distress, one defense mechanism is just to, feel detached from a sense of identity, as because the shock is so profound that you just don't feel as if you were living it. So you feel as if you were not yourself. And number 12, reluctance to pursue interests. This is pretty much related to, feeling that life is meaningless. Also, the DSM-5 requires that in order for this disorder to be diagnosed, that this causes disturbance and causes distress in other people, and also that the bereavement is out of proportion to cultural expectations. As you know, there are some cultures that have mourning rituals that may last very long and that have intense mourning reactions to the death of relatives and loved ones. So the psychiatry and the DSM-5 always has a cultural side to it. So if it is culturally expected for a person to have intense grief, then that's not considered a disorder. So this is why this diagnosis criterion is included here. Also, the DSM-5 asks the psychiatrist to specify whether or not this disorder comes with a traumatic bereavement. So if the loved one was killed, either with homicide or suicide, then there may be additional preoccupation with the deceased's last moments and sufferings. So when you make a diagnosis, you have to specify whether or not this additional element is present or not in the patient. There are some risk factors in this disorder. I mean, people who have a first-degree relationship to the deceased, they may be at an increased risk of developing this disorder. People who suffer from separation anxiety in childhood also are at a greater risk. People who had controlling parents. In the case of widows, widows who had a poorly functioning marriage or were very insecure and therefore they had an insecure attachment style prior to widowhood, they are at a greater risk of developing this disorder because, well, they can't take care of their own anymore because their spouses always took care of them. So that may lead them to this intense grief disorder. And also emotional dependency on the deceased. Well, this is very similar to the risk regarding the widows. And also a lack of preparation for death. It's always a lot of psychologists and philosophers have said that we should face death, we should become more used to death, and because this will prepare us better when some relatives die, and we will be at a decreased risk of developing this disorder. There have been some cultural critiques that Western civilization tries to sanitize death too much. So we're not really used with images of dying. People die in hospitals, and we don't get to be around them when they die. And that desanitation or that sanitation regarding death may ultimately harm us a little bit in the sense that we're not prepared for death. So this lack of preparation for death may be an increased risk factor when it comes to the bereavement disorder. And for our last point, let's talk about what are the usual physicians' response to death. So this is very important for you as physicians. Well, usually the response to death from the physicians is, first of all, a support to the dying patient and the patient's family. It's important for the physician to keep confidentiality in discussing the patient's details. Physicians must be sensitive as to how much information should be given, depending on the patient's reaction. But remember that ethics requires us confidentiality. So you cannot discuss the details of a case with a patient's relatives unless you are authorized to do so. It is a fact that patients suffer emotional blows. That physicians suffer emotional blows when patients die. So, physicians need to have enough psychological maturity in order to overcome this. Some physicians try not to be too involved with patients to avoid emotional blow when these patients die. But that's not really an ethical option. You have to be empathetic to the patient. That's what your profession requires. And if that is an emotional blow later on, well, you have to swallow it up, and you have to learn how to deal with it. But being emotionally detached from a patient and not being too involved with them out of fear that you may be emotionally affected when they die, that's not really a sensible ethical option. Okay, that wraps up our lecture. Let's do a couple of USMLE questions as review. That covers the topic that we talked about today. So a physician has just diagnosed a case of terminal pancreatic cancer in his 16-year-old man. Which of the following statements regarding the reactions and behavior of the physician is the most true? The physician should inform the family but not the patient about the serious nature of the illness. No, not really. The patient has a right to know. And actually, if the patient has not authorized discussion of details with the patient's relatives, then no, the relatives do not have a right because of confidentiality. So A is not a right option. B, the involvement with the patient's family should end when the patient dies. Let's wait to see other options. C, she should provide strong sedation for family members when the patient dies until the initial shock of his death wears off. D, she will feel that she has failed when the patient dies. And E, she will feel closer and closer to the patient as his death approaches. I would say that the most likely response here is D. The patient will feel, the doctor will feel that she has failed when the patient dies, because they were probably emotionally attached to the patient, and of course it will be a big blow, and that's a defense mechanism, self-blame. Okay, let's take a look at another USMLE question. A physician conducts a physical examination on an active, independent 75-year-old woman. Which of the following findings is most likely? A, increased immune responses? No, not likely. Immune responses decrease as you age. B, increased muscle mass? No, absolutely not. It decreases. C, decreased size of brain ventricles? That could be, but let's see the other options. D, decreased bladder control? Or E, severe memory problems? I would say that it's actually C, decreased size of brain ventricles. I'm sorry. No. I'm sorry. It would be an increased size of brain ventricles. I mean, the larger the brain ventricles, the smaller the brain is. And as you age, the brain ventricles actually become increased. So it's most likely D, decreased bladder control. So even if the 75-year-old woman is independent, she may still have a bladder control problem. She may eventually pee or poo on herself. She wouldn't have severe memory problems because although you may lose, your memory functions may decrease a little bit, they will not be severe if the person is independent and active. So here the right answer is D, decreased bladder control. Hello, this is the 6th lecture that we'll cover in our course of behavioral science. The previous 2 lectures were on the developmental psychology, or psychology of development, and those lectures basically cover the great milestones in the lifetime of an individual, from the moment they're born all the way into adulthood. Today we'll cover some of the aspects of psychology when individuals reach the end of their lives. That is to say, when they age, when they die, and how other individuals cope with a loved one's death, which is a grief and bereavement. So this is going to be basically the 3rd lecture in the topic of developmental psychology. But it also will introduce a disorder that is covered in the DSM-5. Keep in mind that the DSM is the Diagnostical Statistical Manual that is used in psychiatry. It is currently in its 5th edition. So this is, at least in the American setting, in Europe it's a little bit different, but in America, this is, so to speak, the Bible of psychiatry, because it's where all the mental disorders are categorized and where the criteria for diagnosis is given. So we will we'll take a look at these disorders with much greater detail later on, but today will be the first one that we'll introduce. But of course, within each country, there are differences too, especially if the country is ethnically or socioeconomically diverse. So you see the United States there has a darker shade, but I bet that if we take a map of the United States, we can see that ethnic groups that are more marginalized, such as African Americans or Latinos or Native Americans, their life expectancy is lower. So this is an important variable that is taken into account usually by the United Nations or other institutions to watch the development of countries. Life expectancy is usually a priority. So you can tell a lot about how well a country is working depending on how long people live. Now let's keep in mind that social development is not the only factor in longevity. I mean, there are other factors as well, including genetic factors. So a family history of longevity is important. I mean, there have been studies finding out that people who tend to die in older age, well, that trait runs in the family. So genes do have a part, but it also has to do with the environment. So continuation of physical and occupational activity. If you are too, as I was saying, if you're too stressed during your work years, well, that will eventually take a toll on you, and that will decrease your life expectancy. Also, advanced education or life expectancy. And it could also be said that that's the way it works worldwide. Countries with higher socioeconomic variables, with socioeconomic indexes, they usually have a higher life expectancy. Although it's not a perfect correlation, because the United States is maybe the most powerful country in the world, but it's not necessarily the country with the greatest life expectancy. But overall, it is true that the better, the more developed a country is, and the better the lifestyle, well, the greater the life expectancy. It's important to know here two terms that we'll be using and that physicians use all the time. One is gerontology, and gerontology is the study of aging, whereas geriatrics is the care of the elderly. So we'll take a look at this as we go on. Okay, so here is a map of life expectancy across the world. As I was telling you, those countries that are in the darker shade have a higher life expectancy, whereas those countries with a lighter shade have a shorter life expectancy. You can make the case that the more developed a country is, the more economically prosperous, the more safe in terms of security, the less crime there is, and so on. Well, the greater the chance a person living in that country has of increasing their life. A much better situation right now. In the United States, people die around the age of 76. Usually for women, life expectancy across all countries is usually a little bit longer, and that may be due to a number of different reasons. The most common hypothesis has to do with the fact that since men are more involved in labor activities, well, that so to speak wears them down more, or they have more stress. So the more stressful you are, well, the less you're expected to live. And actually, you can see some pictures of American presidents, of how they were before and how they are now. And being an American president is a job that has a lot of stress, and that makes you age quicker. So that's why that's one of the hypotheses over why women have a longer life expectancy than men. So it varies by race and gender, although differences in life expectancy have been decreasing over the last few years. So at first, women were at an advantage, but over the last few years, it has been more equalized. Usually, obviously, social economic groups and ethnic groups that are more privileged than others. So, for instance, in the United States, whites over blacks, because, well, blacks because of all the history of racism and slavery and so on. Usually the groups that are more privileged have a higher, and this is the first time we're actually using the DSM, so it's important for you to know what the DSM is. And just to let you know that every time there's a new edition, there are some changes in the DSM. And usually the way this works is that a group of American psychiatrists get together and they discuss some of the mental disorders that are in the previous editions, and they vote on what the changes should be for the next editions. Okay, so let's begin with aging, death, and bereavement then. Keep in mind that all of these topics are included in the USMLE. So when we finish today's lecture, we'll do some review questions that resemble the ones that appear in the USMLE and that have to do with today's topic. So let's begin with the topic of life expectancy. Well, life expectancy is the statistic of how long do people live throughout the world. In the United States, it is about 76 years old. So that's the mean age when people die in America. There has been a dramatic increase of life expectancy throughout modern times. I mean, if you go back 2 or 3 centuries ago, life expectancy was very, or far lower than today. And there's a lot of people who complain about how wonderful life was in the past and how terrible it is today. But I don't think they get the whole picture. I mean, if, at least in terms of life expectancy, we have a